Hello and welcome. We are here today to conduct a comprehensive examination of a subject that is, well, it's frequently misunderstood, often stigmatized, and scientifically very complex.
It is. We're looking at a condition that has been described in psychiatric literature for nearly a century, yet it still remains a focal point of intense debate.
A huge amount of debate. We're talking about diagnosis, gender, neurobiology, the list goes on. The topic for our discussion is borderline personality disorder, or BPD.
And in some regions, you'll also see it referred to as emotionally unstable personality disorder, or EUPD.
Right. And it's a condition that really challenges our understanding of the boundary between, personality and pathology.
It absolutely does. It forces us to look at how the brain regulates emotion, how we form an identity, and how our genetic makeup interacts with our early environment to shape who we ultimately become.
Exactly. And to start, I want to move away from the common cultural perception of this disorder, which often just defaults to pejorative terms like mood swings or difficult behavior. I want to look at a very specific biological analogy that comes up in the research.
I think I know the one you mean.
The psychologist Marcia Linehan, who is a key figure in this field, described individuals with this condition as being the psychological equivalent of an emotional burn victim.
It's a very potent analogy.
It really is.
When you think of a physical burn victim, their skin, which is their protective barrier against the outside world, it's compromised.
Complete.
Even the slightest touch, a breeze, a change in temperature, it can cause excruciating pain. Linehan applies this exact concept to the emotional system.
So the biological reality of BPD involves a heightened sensitivity to emotional stimuli, things that wouldn't even register as painful for a neurotypical individual.
Precisely. And it isn't just about feeling things more intensely, is it? It's about the duration, the recovery time.
Yes, the literature describes a very specific trajectory. It's a high sensitivity to stimuli, an immediate and very intense response, and then a very, very slow return to an emotional baseline.
Correct. For someone without this condition, an emotional upset, it might resolve in minutes, maybe hours.
Sure.
For someone with BPD, that physiological arousal, the stress response, can take much, much longer,
Which means they're often entering the next emotional event before they've even recovered from the last one.
leading to a state of chronic emotional accumulation. It's like a debt that keeps growing.
So our mission for this discussion is to unpack the reality of that experience. We're going to try to move beyond the labels of manipulative or attention-seeking that sadly persist even in some healthcare settings.
And look at the clinical, genetic, and neurological data instead.
Yes. We have a lot to cover. We'll get into the history of the term borderline, this really significant gender paradox in diagnosis, the specific brain structures involved, and then at the end, the surprisingly hopeful data about prognosis.
It is a comprehensive profile. So we should probably begin with the core phenomenology, what the condition actually looks and feels like from a clinical standpoint.
Let's start with the definition. The DSM-5, the Diagnostic and Statistical Manual, it characterizes BPD as a pervasive pattern of instability.
A pervasive pattern, yes, that's key. It's not an occasional thing. It's a consistent feature of their experience.
But instability, that sounds a bit abstract. When we look at the specific criteria, this 9-criteria framework where you need 5 for a diagnosis, what are we actually seeing in a person's life?
We're seeing a desperate struggle for stability. One of the most prominent criteria, and maybe the one that drives a lot of the behavior, is frantic efforts to avoid real or imagined abandonment.
That fear is central.
It's paramount. Then there's the chronic feeling of emptiness, it's very distinct from depression. It's more of a sense of a void, a lack of self.
And what else?
We also see inappropriate, intense anger, or just difficulty controlling anger. And that's often a direct response to that perceived abandonment or rejection we mentioned.
I want to focus on a specific concept that comes up again and again in the literature because it seems so central to how relationships are experienced. That's the concept of splitting.
Splitting is absolutely core to the disorder.
Can you explain the mechanism? What is it?
Well, in psychoanalytic terms, it's a defense mechanism. It's the failure to integrate the positive and negative qualities of the self and of other people into a cohesive, realistic whole.
So most people can understand that a friend or a partner is, a good person, but they can still do annoying things. We hold both ideas at once.
Exactly. You can be annoyed with someone you love. In BPD, that integration fails, especially under stress. So the perception oscillates. It flips between extreme idealization and extreme devaluation.
So a person is either an angel or a devil. There's just no middle ground.
Precisely. And this shift can happen incredibly rapidly with very little warning.
You see this in the relationship patterns described in the research, right? There's this butterfly-like pattern.
Right, where the individual flits in and out of many transient relationships. The idea is to avoid the pain of deep connection, so they never get close enough to be abandoned.
But then there's the opposite, the attached pattern.
The attached pattern involves fewer relationships, but those relationships become deeply, deeply intertwined and often very tumultuous. The fear of abandonment is so high that they cling on, even when the relationship is destructive.
There's a striking historical example of this in source material involving the painter Edvard Munch.
Oh, yes.
Modern psychiatrists have looked at his life and his work and suggested he may have had borderline personality disorder. And his relationship with a violinist named Eva Mudoci is, well, it's a textbook illustration.
A classic case study in that idealization-devaluation cycle.
He painted her. At the start of their relationship, he produced a lithograph. It was called The Brooch. And he described it as, quote, a woman seen by a man in love. It's soft, it's admiring, it's idealized.
All good phase.
Exactly. But then, just days later, the dynamic completely shifted. He depicted her as Salome, the biblical figure. And he described her as bloodthirsty and cannibalistic.
That is the visual representation of splitting. The object of affection becomes the object of persecution almost overnight.
Yeah.
It's not that Eva Mudoci changed in those few days.
Yeah.
It's that Munch's internal filter, the lens through which he perceived her, had flipped entirely from all good to all bad.
And this instability isn't just external, is it? It's not just about how they see others. It turns inward. The literature talks about internal splitting.
Yes, and this connects directly to another one of the 9 criteria, identity disturbance. The source material describes a chameleon-like adaptation of identity.
What does that mean exactly? Chameleon-like.
Because the core sense of self is so unstable, the individual might change their values, their morals, their career goals, even their style of dress, based entirely on who they're with at that moment. They're trying to find an identity by mirroring others.
And the internal splitting.
It vacillates between seeing oneself as a good person who has been mistreated, which is what fuels that intense righteous anger, and seeing oneself as a bad person with no value, which fuels the self-destruction and the chronic emptiness.
That sounds incredibly disorienting. I mean, to not know who you are from one day to the next, or even 1 hour to the next?
It creates a profound sense of disorientation. The research indicates that this is why we see such high rates of dissociation in this population. Right. It's a disconnect from your emotional and physical experience, because the reality of that fluctuating identity is simply too painful to inhabit continuously.
So let's pivot now to the biology. For a long time, the prevailing view in society, and even in parts of psychology, was that this was purely a result of upbringing, the bad parenting model.
That was the dominant theory for decades.
But the modern data suggests a very, very strong biological component.
The debate between nature and nurture is particularly relevant here, but the data is really settling on a strong interaction of both. The heritability estimates for BPD are significant. They range between 37% and 69%.
69%. That's a substantial genetic load. That places it on par with, or even higher than, many other psychiatric conditions like major depression or bipolar disorder.
It absolutely does. This isn't something that just appears out of nowhere. There's a predisposition.
And we actually have specific studies that are starting to pinpoint where this might live in the genome. There was a study, I believe it was conducted in the Netherlands by Troll and his colleagues. They looked at siblings and parents.
Yes, that was a very significant study. It was one of the first to link BPD characteristics specifically to genetic markers on chromosome 9. It helped to validate that we are, in fact, looking at a biological transmission of vulnerability.
And it wasn't just chromosome 9. There's also mention of chromosome 11.
That refers to something called the DRD47 repeat polymorphism. It's a bit of a mouthful.
It is.
But essentially, it's a variation in a dopamine receptor gene. And this specific variation has been linked to disorganized attachment patterns in infancy, and also to issues with inhibitory control later in life.
So the genetic machinery that regulates dopamine, which is crucial for reward, for motivation, for impulse control, it may be functioning differently in individuals who go on to develop this disorder.
That's what the evidence suggests, a different biological starting point.
So we have a genetic blueprint. Now let's look at the organ itself, the brain. Structural neuroimaging, things like voxel-based morphometry, has given us a look inside the brains of individuals with BPD. What are we seeing there, structurally?
We're seeing consistent patterns of volume reductions in key areas involved in emotional regulation.
So parts of the brain are literally smaller.
Yes, specifically, the hippocampus, the orbitofrontal cortex, and the amygdala tend to show reduced gray matter volume.
Let's break those down. The hippocampus is vital for.
Memory and context. It helps us put emotional reactions into the correct context based on past experience. A smaller hippocampus might struggle with that.
Okay. And the orbitofrontal cortex.
That's part of the prefrontal cortex.
Yeah.
It's heavily involved in decision-making, in weighing consequences, and in impulse control. Reductions there could explain some of the impulsivity we see.
And the amygdala, of course, is famously the brain's alarm system, the fear center.
It is. But the amygdala findings are actually quite complex and, frankly, a bit counterintuitive.
Oh, so?
The assumption for a long time was that the amygdala in BPD patients would just be hyperactive, constantly firing, overreacting. The alarm bell is always on.
That makes sense with the emotional burn victim analogy.
It does. And while we do see issues with the functional connectivity, the communication between the limbic system, where the amygdala lives, and the regulatory prefrontal cortex, some studies have found something surprising,
Which is?
a decreased amygdala activation in response to certain negative stimuli.
That is completely counterintuitive. How do you explain that? An underactive alarm bell.
It suggests that the neurology is not just about overreacting. It points to a unique, innate neurological predisposition to emotional turbulence. The editor of Biological Psychiatry, John Crystal, he noted this. He said this suggests the emotional turbulence is an innate neurological state, not just a reaction to the environment. The brain is simply wired differently in how it processes and regulates emotional pain.
Speaking of pain, there's a very disturbing but incredibly important link between emotional pain and physical pain in this profile.
Yes.
We know that non-suicidal self-injury or self-harm things like cutting, burning, head banging is extremely prevalent. The statistics say somewhere between 50 and 80% of individuals with BPD engage in this.
It's one of the most distressing symptoms for families and loved ones to witness. But clinically, it serves a very specific function.
It's not necessarily a suicide attempt.
It's rarely a failed suicide attempt, although we have to be clear. The overall risk of suicide is tragically high. Up to 10% of individuals with BPD do die by suicide.
A staggering number.
It is, but the non-suicidal self-injury is most often a method of mood regulation. It's a coping mechanism, albeit a very dangerous one.
How does inflicting physical pain regulate your mood?
There are two main theories supported by the data. One is that the sharp, intense physical pain can snap an individual out of a dissociative state. That feeling of numbness or unreality, the pain makes them feel real again.
It grounds them.
In a way, yes. The other theory is neurochemical. The body releases endogenous opioids, its own natural painkillers, in response to physical trauma. These chemicals also have a powerful soothing effect on emotional distress.
So the act of self-harm provides a temporary chemical relief from what feels like unbearable emotional pressure.
It's a desperate attempt to medicate an internal state that feels intolerable.
This brings us right to the intersection of that biology with the environment. We mentioned Marsha Linehan earlier. Her biosocial theory seems to be the gold standard for explaining how this disorder actually develops.
It is the most comprehensive and widely accepted model we have. Linehan's theory is elegant in its simplicity. It's a formula.
A formula.
Biological emotional vulnerability plus an invalidating environment.
So you start with a child who has that biological vulnerability we just discussed, the high sensitivity, the intense reactivity, the slow return to baseline.
Right. But biology alone does not create the disorder. You then have to place that biologically vulnerable child into what she calls an invalidating environment.
Let's define that. Invalidating environment. It sounds very clinical, but what does it actually look like in a household?
It doesn't always mean overt physical or sexual abuse, although it certainly can. An invalidating environment is one where the child's internal experiences, their thoughts, their feelings, are consistently and pervasively trivialized, dismissed, ignored, or even punished.
So if a sensitive child is crying because they're overwhelmed and a caregiver says, "Stop overreacting," or "You're just doing this for attention," that's invalidation.
That is a perfect example of invalidation. The child is being told that their internal emotional compass is wrong.
So they learn they can't trust their own feelings.
Exactly. They learn that their pain isn't real or isn't valid. This has two devastating effects. First, It prevents them from ever learning how to understand, label, and regulate their own emotions. No one ever teaches them how.
And the second effect.
They learn that to get their needs met, they have to escalate. A small expression of sadness is ignored, so they have to get louder, more dramatic, just to be heard, which of course often leads to even more invalidation from the parents. See, you are overreacting. And it creates this tragic, escalating feedback loop.
However, we can't ignore the statistics on severe trauma. The correlation with what are called adverse childhood experiences, or ACEs, is stark.
It is undeniable. Individuals with a BPD diagnosis are significantly more likely than the general population or even other psychiatric groups to report histories of verbal, emotional, physical, and sexual abuse.
And the data on incest and the loss of caregivers in early childhood?
Is particularly high in this population. It's a very strong correlation.
But, and this is a crucial but, not every trauma survivor develops BPD. Not by a long shot.
Correct. And this is where the complexity comes in. Causality is not a straight line. Some people with BPD report no significant trauma history at all. And conversely, many people who endure horrific trauma do not develop BPD.
So what's the variable?
It brings us back to neurodevelopment. Recent research is exploring the idea that underlying traits, perhaps associated with things like ADHD or autism spectrum disorder traits like sensory sensitivity, impulsivity, or difficulties with social cues, might increase a child's vulnerability.
How would that work?
Well, a child with these traits might just be more difficult to parent, increasing the risk of those negative, invalidating interactions. Or they might simply process a traumatic event differently and more damagingly than a neurotypical child would. It's the combination of factors.
This interplay of biology and environment leads us directly into one of the most contentious areas of this whole field of research, the gender paradox.
It is a major point of debate.
If you walk into a clinical setting, a hospital, a DBT therapy group for BPD, who do you see?
You see women. Overwhelmingly. In clinical settings, women make up about 75 to 80% of the people who receive this diagnosis.
A 3-to-1 or even 4-to-1 ratio. But when researchers go out into the general population and do large-scale epidemiological studies, randomly sampling thousands of people,
The gender difference vanishes. In the general U.S. population, the data on lifetime prevalence shows no significant difference between men and women.
that is a massive discrepancy. 3-to-1 in the clinic, but 1-to-1 in the real world. So, where are the men?
That is the multi-million-dollar question. The prevailing theory is that men with the same underlying pathology are being funneled into different diagnostic systems. It comes down to how the symptoms tend to be expressed.
The idea of acting in versus acting out.
Generally, yes. The research suggests women are more likely to internalize the distress. This manifests as depression, anxiety, eating disorders, and self-harm.
And those behaviors lead them to mental health clinics.
Correct. Men, on the other hand, are statistically more likely to act out or externalize their distress.
Which would look like, what? Substance abuse?
Substance abuse, explosive temper, physical aggression, and other forms of antisocial or criminal activity.
And those behaviors don't land you in a therapist's office. They land you in the legal system or in a substance abuse treatment center.
Precisely. So these men are often diagnosed with antisocial personality disorder or intermittent explosive disorder or a substance use disorder. The underlying emotional dysregulation and fear of abandonment might be identical to what's seen in female BPD patients, but it's being labeled differently because the behavioral output is different.
There's a statistic regarding the prison population that seems to support this.
Yes, multiple studies suggest that the prevalence of BPD in prison populations is around 17%, which is dramatically higher than in the general population.
And in studies of intimate partner violence, or IPV.
Those studies show that a diagnosis of BPD in men is strongly associated with the perpetration of both psychological and physical violence against their partners. The core issue, that frantic fear of abandonment and poor emotional regulation, is the same, but the output is aggression directed toward others rather than toward the self.
This clear gender skew in diagnosis has led to a significant and important critique from feminist scholars.
It has. The argument, put simply, is that the psychiatric establishment may be pathologizing women's understandable emotional responses to gendered violence and sexual abuse.
So if a woman has been abused and reacts with hypervigilance, intense fear of abandonment, and emotional volatility, Labeling that as a disordered personality is seen as a form of victim blaming.
That's the essence of the critique. It
Yeah.
places the disorder inside the woman, rather than acknowledging the external societal cause of her distress.
Some experts, like Proctor and Williams, have even suggested we should scrap the BPD label entirely in these cases of clear trauma.
They argue for using the diagnosis of complex PTSD, or CPTSD, instead. This diagnosis specifically acknowledges the external cause, the trauma, rather than implying an inherent flaw in the person's personality.
That makes a lot of sense. But there is a counterargument.
There is. The counterargument is that while there's a huge overlap, CPTSD doesn't fully cover all the core symptoms of BPD. Specifically, that profound identity disturbance and the chronic feelings of emptiness are more central to the BPD diagnosis. So it's an ongoing debate with valid points on both sides.
Navigating these labels is clearly difficult, especially given the history of the term itself. The name borderline personality disorder is, well, it's arguably one of the most confusing and unhelpful names in all of medicine.
It is not very descriptive.
It just begs the question, borderline of what?
To answer that, you have to go back to the 1930s.
Yeah.
The term traces back to a psychoanalyst named Adolf Skern in 1938.
Yeah.
At that time, psychiatry viewed mental illness largely in two big buckets: neurosis and psychosis.
Okay, so neurosis being anxiety, depression, conditions where people are still in touch with reality but are suffering greatly.
Correct. And psychosis being a break from reality, like schizophrenia, with hallucinations and delusions.
So where did borderline fit in?
Stern and his colleagues observed a group of patients who didn't fit neatly into either category. They seemed neurotic, they were anxious, depressed, had relationship problems, but when they were under extreme stress, they seemed to cross the border into psychotic-like thinking. Paranoia, dissociation.
So they were literally seen as being on the borderline between neurosis and psychosis.
That is the origin of the term.
There were some other fascinating names floated around back then. I saw ambulatory schizophrenia in the research.
Yes, ambulatory schizophrenia, pseudoneurotic schizophrenia, cyclothymic personality. There were many attempts to label this group. It wasn't until 1980, with the publication of the DSM-3, that borderline personality disorder was codified as a distinct official diagnosis.
You mentioned the psychotic element. This is something that often gets ignored in the modern pop psychology discussion, which focuses mostly on the mood swings and relationship drama. But the source material indicates that actual psychotic symptoms are a reality for a large portion of these patients.
It's a significant and often overlooked symptom cluster. The data suggests that between 20 and 50% of patients with BPD report experiencing psychotic symptoms.
And this includes things like auditory hallucinations, hearing voices, and paranoia.
Yes. For a long time, doctors tried to diminish this by calling it pseudopsychosis.
As if it wasn't real psychosis, a lesser form.
Exactly. The belief was that these were as-if hallucinations, somehow less authentic than those in schizophrenia. But modern phenomenological research, which focuses on the patient's actual lived experience, suggests that to the person hearing them, these auditory hallucinations are indistinguishable from those experienced in schizophrenia.
They're just as real, just as distressing.
And they often involve critical or derogatory voices, which of course reinforces the core BPD symptoms of shame and self-hatred.
That adds a whole other layer of difficulty to an already unbearable experience. Not only are you fighting your emotions, but you might literally be hearing voices telling you you're worthless.
It's an immense burden.
Now, if we were having this discussion 30 or even 20 years ago, the outlook would be incredibly bleak. BPD was considered a garbage bin diagnosis.
It was. For decades, the prevailing attitude in the healthcare system was that BPD was untreatable, a life sentence. Clinicians often viewed these patients as difficult, manipulative, or treatment-resistant.
Many therapists would just refuse to take them on as patients.
That's right. The stigma was, and to some extent still is, enormous, even among mental health professionals.
There's a reframing of that word, manipulation, that I think is vital to discuss. We touched on it with Linehan, but it really bears repeating.
It does. Linehan argued that what looks like manipulation, for example, calling a therapist late at night and threatening self-harm, is often not a calculated, malicious attempt to control the other person.
It's a cry for help.
It's a desperate, often involuntary attempt to regulate unbearable emotional pain, or to elicit help when they feel they're drowning. If you reframe it as a skills deficit, a lack of ability to regulate emotion rather than a character flaw, it changes the entire treatment approach.
And that very change in approach led to the development of DBT, or dialectical behavior therapy. This is now considered the gold standard treatment.
DBT completely revolutionized the treatment of BPD. It's a form of cognitive behavioral therapy that is highly structured and focuses on teaching 4 specific sets of skills.
Okay, what are the 4 skills?
The first is mindfulness, the practice of being present and aware without judgment. The second is distress tolerance, basically how to survive a crisis without making it worse through impulsive actions.
Which is crucial.
Crucial. The third is emotion regulation learning, to understand, identify, and change emotions. And the fourth is interpersonal effectiveness, learning how to ask for what you need, say no, and navigate conflict without destroying relationships.
There's also another therapy mentioned, mentalization-based treatment, or MBT.
MBT comes from a slightly different theoretical background, more psychodynamic. It focuses on developing the capacity to mentalize, which is the ability to understand one's own mind and the minds of others.
How does that help?
Since people with BPD often misinterpret the intentions of others, seeing rejection or anger where there is none, MBT helps them learn to pause, get curious, and check their assumptions before they react.
What about medication? Is there a pill for BTD?
That's a common question, and the answer is no. There are no medications approved by the FDA or any other regulatory body specifically to cure BPD.
So when people with BPD are on medication, what is it for?
The medications are used strictly to treat co-occurring conditions or comorbidities. An antidepressant might help with an underlying major depression. A mood stabilizer might help reduce impulsivity. An antipsychotic might be used for those psychotic symptoms. But there is no pharmaceutical fix for the core personality structure itself. Therapy is the primary treatment.
So with these therapies like DBT and MBT, what is the prognosis? This is the part of the research that I found most surprising and frankly most hopeful. The old view was once borderline, always borderline.
That view is now completely outdated. The data says otherwise. BPD actually has one of the best long-term remission rates of any major mental illness.
Let's look at the numbers because they are startling.
They are. Short-term studies show that up to 45% of patients remit, meaning they no longer meet the 5 out of 9 criteria for the diagnosis over relatively short periods of a few years.
And the long-term data.
The long-term data is even better. A major landmark 10-year follow-up study found that 86% of patients achieved at least a 4-year sustained remission.
86%, that's a massive majority. That completely upends the old idea of it being a life sentence.
It does. The disorder seems to have a natural burnout rate. The most acute symptoms, particularly the impulsivity, the self-harm, and the stormy relationships, tend to diminish significantly with age and with treatment.
But there is a caveat in the research.
There is. While the symptoms remit, what we call functioning, social and vocational functioning, takes much longer to recover.
What's the distinction there?
A person might stop cutting themselves and stop having explosive outbursts, so technically they are in remission. They no longer meet the criteria. But they might still struggle to hold down a full-time job or to maintain a stable long-term partnership. The social and vocational recovery often lags behind the symptom recovery.
This trajectory just highlights the importance of early intervention. Which brings us to the controversy of diagnosing adolescents. For a long time, doctors were terrified to diagnose a teenager with BPD.
The hesitation was understandable. It came from the fear of stigma. Clinicians didn't want to saddle a 15-year-old with a personality disorder label, which sounds so permanent.
And they also argued that normal teenage angst looks a lot like BPD. Mood swings, identity issues, impulsivity. That's standard for adolescents.
That was the argument. But the consensus has now firmly shifted. We know that avoiding the diagnosis was actually doing more harm than good.
How so?
We now know that the diagnosis is valid and reliable in adolescence. If you have a teenager who is consistently self-harming, has intense rejection sensitivity, and a pattern of unstable relationships, waiting until they're 18 or 21 to treat it just allows those maladaptive patterns to become more deeply entrenched.
So early detection allows for early intervention with things like DBT for adolescents.
Which can alter the entire life trajectory of that young person significantly. It prevents the emotional burn victim from accumulating more and more burns before they get help.
Exactly. Now, before we conclude, I want to touch on the idea of subtypes. We've talked about BPD as if it's a monolith, but a psychologist named Theodore Millon proposed that there are distinct flavors of this disorder.
Millon's subtypes are very useful for understanding the diversity within the diagnosis. He identified 4 main types. First, there's the discouraged borderline.
What does that look like?
These individuals are more pliant, submissive, and loyal on the surface. They cling to relationships. They feel vulnerable and constantly in jeopardy. They tend to look more like they have dependent personality disorder or a severe depression.
That's very different from what he called the impulsive type.
Correct. The impulsive borderline is the presentation most people think of. They can be seductive, capricious, flighty, and frenetic. They fear loss, but become agitated and gloomy when their needs aren't met. This presentation overlaps a lot with histrionic traits.
Then there's the petulant type.
The petulant borderline is defined by negativism and passive aggression. They are often impatient, restless, stubborn, and defiant. They are easily slighted and become quickly disillusioned with others, oscillating between explosive anger and sulking.
And finally, the self-destructive type.
This type turns the anger and hatred inward. They are intrapunitive. They might be deferential and appeasing to others, but they punish themselves severely. This is the subtype where we see the highest risk of suicide and the most severe forms of self-harm.
It really emphasizes that this is a spectrum of pain processing. It's not a single character flaw. It's a complex interplay of how a person's biology and history cause them to relate to themselves and the world around them.
And if we connect this to the bigger picture, it raises an important question about how we view high sensitivity in general. High sensitivity to social rejection, rejection sensitivity, seems to be the core engine driving this disorder. It's then moderated by a person's level of executive function.
So if you have that high sensitivity, but you have low executive control, a low ability to plan, regulate, and inhibit impulses, you get the symptoms of BPD.
Precisely. It suggests that what we call a disorder might actually be better understood as a neurological incompatibility between a highly sensitive emotional system and an invalidating or at least overwhelming world.
That's a profound shift in perspective. Instead of seeing a difficult person, we are challenged to see a system under an immense and constant load, struggling desperately to maintain some kind of equilibrium. It challenges all of us, really, to be more validating, more understanding, and more aware of the biological reality that lies just beneath the surface of the behavior. Thanks for listening.